Dr. Ree is not able to be here today, so we're going to move on to Dr. Cameron. Dr. Cameron graduated from the University of Minnesota, followed by residencies at both Beth Israel Medical Center and Mount Sinai School of Medicine in New York City. Dr. Cameron is widely recognized for conducting epidemiological research while practicing medicine. He has been viewed as a pioneer in Lyme disease and as an author of practice guidelines, analytical reviews, and clinical trials. He has published 9 peer-reviewed articles based on his research in the past 5 years alone. Dr. Cameron has led ILADS to new heights as president from 2007 to 2009. He has testified as an expert on Lyme disease for legislation in Connecticut, Massachusetts, and Pennsylvania for physicians' rights to diagnose and treat Lyme disease. He has been interviewed as an expert on NBC Today Show, Good Morning America, Fox News, Sirius Radio, and many, many newspapers and other publications. He currently sees patients in his private practice in Mount Kisco, New York, while continuing his research and writing. He maintains his website. It's called lymeproject.com. It's very interactive and interesting. And today he will give us an update on the guidelines. Thank you.
Thank you, Andrea. I have to say that when I went to medical school at the University of Minnesota and went to become an epidemiologist at the same time, I never realized that treatment guidelines would become so important and they would use so many epidemiology terms that I had used at the University of Minnesota. So it's taking a rather boring topic and making us live with it in medicine. Now, I'm very excited, even though I was in school in the 70s, to see doctors who are students coming through the physician training program that Turn the Corner supports. It's exciting seeing Sarah Buckman present some great work. I see more and more students now who are coming through and picking as their thesis, as their research interest, Lyme disease. And it's even Dr. Ree had been through the physician training program, have been writing on a really important topic, which is the neuropsychiatric problems when you have strep and the neuropsychiatric problems when you have Lyme overlap so much. The other interesting thing is that if you have been told you have pandas as a kid, since that looks a lot like Lyme disease, we were trying to get a paper ready so that we could get it accepted in time for this meeting, but publications always run into little wrinkles. But just be in mind that the crux of this issue is that any diagnosis you get, you have to at least think of Lyme disease because it mimics the Lyme so much. Okay, next, how do you move the slide? Right here? Yes. How do you do this? I need more technical help here. Oh, the green one. Okay. So right now there's guidelines that have emerged. And so therefore, instead of you and I reading the evidence, we come to this meeting and hear evidence. There's so many experts that come to this meeting. What we've been doing is putting our lives in the hands of a panel of people who say, hey, I've read the evidence, and this is what I conclude. This is the answer. And so it started out that the IDSA said in 2000 that there was no such thing as chronic Lyme, and it wasn't more than aches and pains of daily living anyway. And that was a rather odd interpretation of the evidence. And as an epidemiologist, it was rather frustrating to rely on somebody else reading the evidence. I'd rather be able to continue to read the evidence. I work with ILADS members since that time to try to look at the evidence and write guidelines so that doctors can have a different view of how to look at medicine. So in 2006, we were hoping by writing our guidelines as ILADS, by writing analytic reviews, that we could get a more balanced guideline. But unfortunately, the IDSA came up with conclusions that the vast majority meet the CDC surveillance criteria, The two-tier lab test, which is the ELISA and the Western blot, should be positive, so they use the word is expected. 10 to 20 days of antibiotics is effective. Chronic Lyme disease does not exist. Chronic Lyme disease symptoms are nothing more than aches and pains of daily living. No evidence of persistent infection, and treatment for chronic Lyme disease is not effective. Now, this is what they call evidence-based medicine. They look at the evidence, they look at the quality of evidence, and come to this conclusion. Now, what's interesting, when you look at the rules to look at evidence, there's something called level 1, 2, and 3. Level 1 means a properly randomized clinical trial. The problem is that the NIH trials are flawed. So just saying you have a double-blind randomized placebo study is not good enough. ILADS says, hey, you need a lot more than just calling it a trial. The IDSA had said, well, gee, if the NIH trials are so good, why bother looking at other trial designs? Why look at clinical experience? Why look at all the expertise that ILADS brings to the table? And why not use clinical experience? Why not allow some growth? So we're not alone as ILADS of saying, hey, we got to do better, look at the evidence than what the IDSA did. There were 2 papers that were published in the past year and a half that looked at all of the IDSA guidelines. And there were actually thousands of guideline recommendations covering tuberculosis, AIDS, TB, and only 14 to 16% had a proper, well-designed study. And so it shows that most of the recommendations, no matter what the disease is, still uses clinical judgment, even in the IDSA guidelines. The impression is everything's proper. So with such a small number, we're not alone, and it's nice that there's a backlash. There are people who, beyond ILADS, who are saying there's something wrong with these small panels who come up with these very skewed decisions and skewed conclusions. Another development is that the Institute of Medicine came along and had a big hearing and a big statement that says we need to develop trustworthy clinical practice guidelines. Not guidelines, not practice guidelines, but trustworthy guidelines. The IOM said, if we're going to have guidelines, we're having problems because there's variable quality of the studies, there's limitations in the systemic reviews, there's lack of transparency. They're not telling you who's developing and why they're developing and what their stake is in these types of guidelines. Failure to convene multi-stakeholders. They didn't include, in Lyme disease, for example, they didn't include people who had experience in treating chronic Lyme, but they often don't involve patients, and so it shows up in a lot of problems. Unmanaged conflict of interest, overall failure to use rigorous methodologies. So what ILADS did again, just like we did in 2004, is we pulled together a lot of the experts that you see at this meeting. 16 of the 17 people that are on the group are at this meeting, active at this meeting, presenting at this meeting. You're running into them all the time. And includes people like Betty Maloney with family practice, and you go down the list, Shay from Russ, Jemsick from infectious disease, Dr. Leventhal, a psychologist, Manhattan, Andrea, who's our moderator, as a rheumatologist from New Jersey, Dr. Harris, immunologist from California, Horowitz, internal medicine in Hyde Park. DeLong is not here, but she just works a lot as a statistician at Brown, was helpful in the IDSA hearing. Dr. Ligner in Armonk, Dr. Green, who got elected to the board from San Francisco in family practice, Dr. Shore, Washington University, Reston, Virginia, Dr. Lorraine Johnson, JD from California, CALDA, that's now called Lyme Disease Organization, Dave Marks is internal medicine hematologist, Joe Burrascano, internal medicine, Bob Bransfield, who was our president, and Ray Stricker. So ILADS looked at the same evidence, the same strength of the evidence, the weakness of the evidence, and said, hey, Lyme disease can be difficult to diagnose, can persist for years, can be severe, can be associated with co-infections, can be difficult to treat and can be costly on the same evidence. So I want to show you how we got to that conclusion. ILADS is using something called a grade. So instead of writing that there's problems with the Clemton trial, they were sick for 4.7 years, they had 3 previous treatments, this says instead of looking at analytic reviews, you actually judge the evidence for, is it quality evidence? Is there consistency in the data? Is there generalizability? Can you generalize it to the patients that are right in front of you? Because most patients are an N of 1. That means they're in front of you and you got to figure out what to do with them and what's the size. And so instead of the IDSA saying, oh, it's a trial, it's a double blind, that's good enough, the grade says you need a lot more evidence than that, a high quality evidence, and this gives you the grade. How do you judge that evidence? And so all of these, everybody in this room who knows the evidence has some limitations, this is a formal, organized way to put the pressure on the guidelines and give more clinical flexibility. So in the grade, and this is the last step of writing the guidelines, we took these 3 questions as an example. Like, is a single dose of 200 milligrams of doxycycline following a tick bite effective? Is 10 to 20 days enough for Lyme, 10 to 20 days of antibiotics? And the third is there sufficient evidence to deny antibiotic therapy? So we're working through the language of those questions. So these are key conclusions that came out of the IDSA guidelines, and it's pretty easy to show that there's only one trial for the 200 milligrams of doxycycline, and the data is very weak, and they didn't look at anybody more than 6 weeks. And if you don't look at anybody more than 6 weeks, how are you going to know that 200 milligrams of doxycycline is going to do a thing for chronic Lyme, for long-term manifestations? And I think Betty Maloney yesterday presented a nice overview of the second question, which is, does 10 to 20 days in these trials work at a year later? And there's at least 15% in many cases where they know they had problems, they know they had to get retreated, or they know they were sick. And then there was a huge loss of follow-up, sometimes 20 to 30%. And so if you look at what they call intent to treat, the numbers for intent to treat show we don't have enough data to support the short-term treatment for EM rash, and that's just EM rash. It has nothing to do with what happens if you're on steroids, what happens if you have more complicated delays treatments that was just talked about in the previous session, and what happens if they've been sick for a while. What happens if they have co-infection? So in grade, when you make a recommendation, if you have such good data, so good, so compelling, you don't have to tell the patient anything except for this recommendation stands, I don't have to treat, I don't have to discuss the options, I don't have to discuss anything. But when there's weak evidence, which happens with these trials, at that point with weak evidence, you have to come up with what they call weak recommendations. So on paper, that's how we get to that conclusion. And the way it works, if you have weak recommendations, where you can say, hey, there's support for longer term treatment, there's not enough support to prove everything yet, you have to, according to Guyot, you have to recognize that different choices will be appropriate for different patients.